Orientation and Attention Intervention Following a Brain Injury. It's by me and Gavin. To start off with a few definitions, we have orientation, which is the awareness of oneself in relation to their surroundings. Attention, a fundamental function that influences the performance of components of cognition, such as memory and execution. And traumatic brain injury, or TBI, and this is changes in brain function that result from external forces on the brain, characterized by physiological and functional changes such as attention and cognitive deficits. These deficits can include loss of consciousness, memory, and changes in mental state. And the populations most affected by traumatic brain injuries are the American Indian and Alaskan Native population, those 75 plus, and low-income population. To start with an overview on our first four articles, we have attention training after moderate to severe traumatic brain injury in adults, and this was a systematic review. As this was a systematic review, it was a level 1 evidence, so it was extremely reliable. And a little bit about this article, it reviewed 21 different articles. They all varied in methodological quality. Their objective was to determine the extent and efficacy of attentional training as neurophysiological rehab to improve attention deficits in adults that varied from moderate to severe traumatic brain injury, and these were blindly reviewed by 2 reviewers who assessed the criteria. Our second article was Cognitive versus Functional Approaches to Commentary on a Randomized Controlled Trial. This was a level 5 evidence as it was a commentary on a randomized controlled trial, so this was a little bit lower reliability. The objective of this was to describe and interpret evidence from the randomized controlled trial and highlight the clinical implications. 366 participants total participated, and they were split into cognitive, didactic, and functional experiential rehab groups, and there were adult veterans with moderate to severe TBI sustained within 6 months. Our next article was Rehabilitation for Impaired Attention in the Acute and Post-Acute Phase After a Traumatic Brain Injury, a narrative review. This was a level 5 evidence as it was a narrative review, so a little bit lower. The objective was to give clinicians and researchers an overview of how attention deficits after a TBI are assessed and treated throughout the early and late recovery process. Qualitative synthesis of many bodies of evidence was based on assessment approaches, screening for contributing conditions, and rehabilitation strategies. Our next article was Training in Goal-Oriented Attention Self-Regulation Improves Executive Functioning in Veterans with Chronic Traumatic Brain Injury. This was a level 2 evidence study as it was a randomized controlled trial, so this has a little bit of a higher reliability. The goal of the study was to assess whether cognitive rehabilitation training that was successfully applied in chronic civilian brain injury would be effective for military veterans with traumatic brain injuries. This included 33 veterans with chronic TBI and executive difficulties in daily life were used in the control trial. Our next set of articles were Cognitive Rehabilitation Following Traumatic Brain Injury. This was a level 5 evidence as it was another narrative review. It reviewed concepts, mechanisms, severity, impairments, and rehab strategies without a systematic methodology or meta-analysis, which replaced it as a narrative, non-systematic review. Our next article was Early Attention Training After Acquired Brain Injury. This was a level 2 evidence as it was a randomized control trial. This consisted of a 2-year follow-up participants from a previous randomized control trial, comparing timing and type of intervention. No new randomization occurred at the follow-up, and the study does level 2 evidence because the outcomes are from an original randomized control trial with predefined groups and controlled comparisons. The next article was called Changes in the Components of Visual Attention Following Traumatic Brain Injury, a Systematic Review and Meta-Analysis. This was a level 1 evidence because it was a systematic review and meta-analysis, so it had very, very good reliability. Explicit inclusion and exclusion criteria were used. It synthesized findings from multiple studies and conducted a quantitative meta-analysis that reported effect sizes, assessed heterogeneity, and included subgroup analyses and meta-regression. Our final article was called Visuospatial Attention Allocation as an Indicator of Cognitive Deficit in Traumatic Brain Injury, a Systematic Review and Meta-Analysis. This was another level 1 evidence due to its systematic and meta-analysis description. This used explicit inclusion and exclusion criteria, synthesized results from multiple studies across TBI severities, and did quantitative meta-analysis including effect sizes, heterogeneity analyses, subgroup analyses, publication bias assessments, and a meta-regression.
Now we're going to talk about some interventions. First, traditional interventions involve graded and structured tasks that target different domains of attention. These activities usually start simple and gradually become more complex. Common examples include pen and paper activities and therapist-led drills designed to practice specific attention skills. Another approach is with technology. These use digital tools such as cognitive training computer games and computerized training programs that provide repeated attention-focused exercises. One example is attention process training, or APT3, which targets different attention domains with progressively challenging activities. The virtual reality is also being used to replicate real-life environments, allowing for people to practice attention skills in more immense settings. There's also pharmacy interventions, which involve medications that help improve attention arousal and processing speed. Another strategy uses environmental modifications. These focus on reducing distractions and improving organization. Examples include creating structured schedules, using reminders, and modifying the environment to support better attention. Finally, combination interventions integrate multiple approaches. For example, computerized programs may be used alongside traditional pen and paper tasks to reinforce attention training. So like physical activity can also be incorporated, and dual task training may be used to improve divided attention skills.
Next is strategy training. This approach focuses on teaching metacog strats to help individuals recognize distractions and redirect their attention. It may also include mindfulness-based tech strategies to improve sustained and selective attention. Training can occur in small groups or individual sessions and often include homework practice so individuals can apply strategies outside the therapy. These interventions focus on retraining cog processes through didactic instruction, therapist feedback, and guided processing strategies. Another important component is education. Brain health education helps individuals understand how attention and other cognitive processes affect their daily functioning. This education also focuses on helping individuals recognize behaviors that support better cognitive performance and overall brain health. Functional practice is also commonly used. This involves task-oriented training within daily activities and routines. Individuals practice meaningful tasks repeatedly while the therapist provides guidance and sequencing in task completion to help relearn daily activities. Lastly is goal-oriented approaches, which help the individual develop strategies to plan and manage tasks. These approaches may include time pressure management, working memory training, and metacog strats. Programs such as goals training encourage individuals to identify their own goal, create priorities, and practice applying strategies within real-life contexts. Another intervention is Cog Rehab Program. This approach involves structured interdisciplinary Cog retraining using repetitive and graded exercises that target attention, memory, and executive functions. It also incorporates comp strategies and real-world practice through therapist-led sessions and caregiver-supported activities. Some of the articles included in the review focused on assessment rather than treatment. For example, certain studies measured visual attention using tasks such as Posner queuing, cancellation tasks, and visual search, which are used to evaluate attention deficits but do not provide an intervention. One study specifically used Cog Rehab through attention training, where participants completed structured therapist-led exercises designed to retrain attention skills after brain injury. Lastly, another study was a research synthesis, meaning it analyzed results from multiple studies that measured visuospatial attention after TBI and calculated effect sizes, but it did not test or provide a treatment intervention.
For a synthesis of our results, we found that structured cognitive rehab helps people with TBI by improving their thinking skills and their daily functioning. Interdisciplinary programs improved attention, memory, executive functioning, and overall independence. Combining restoration and compensation strategies was found to be the most effective approach. Cognitive rehab was an important option to improve quality of life and community reintegration for people with moderate to severe TBIs. TBIs significantly worsened visual attention overall. The biggest problems found were in selective attention and shifting attention, while sustained attention was less affected. People with moderate to severe TBI had much larger deficits than those with mild TBIs. Reaction time was more effective than accuracy, meaning people were usually slower rather than more incorrect. Mild TBIs mainly affected processing speed, while moderate to severe TBIs affected both speed and accuracy. Visual attention problems in mild TBI may last many years, while people with more severe TBIs may improve over time, possibly due to rehab. Those who started attention training early, within 4 months after their acquired brain injury, were found to have better long-term outcomes about 2 years later. The early group had a better quality of life, fewer activity limitations, and better workability, and higher return to work rates than those who started later. The type of training was found to matter less than when the training started, although early attention processing training showed slightly better work outcomes. Starting cognitive attention rehab early led to better long-term recovery and participation. TBI causes significant visuospatial attention deficit disorders. The severity of injury mattered a lot, finding that mild TBI had small deficits while moderate to severe and severe TBIs had much larger impairments. Attention problems were worse in higher-level tasks and less affected in automatic attention. Evidence showed attention improved over time after injury, especially with mild TBI, though recovery in severe TBI may take years. Visual attention is reliably impaired after TBI, especially with greater injury severity and complex attention demands. Some participants improved marginally, but most remained in the severe impairment range throughout the studies. There were inconsistent attentional improvement patterns following interventions. Some improved performance in behavioral and cognitive areas, but not all attentional domains. Overall results were mixed, but add to the evidence currently growing that inform neuropsychological rehab practices. Attention deficits following TBIs are very common and affect many areas. Some deficits improve on their own, but most benefit from structured rehab, ongoing assessments, and treatments early on. Combining assessments seems more beneficial, but more studies are needed as the current level of evidence supporting rehab strategies is not very solid. The intervention groups demonstrated greater executive functioning improvements than the control groups did. They showed improvements in goal management, cognitive control, attention regulation, improved functional task outcomes, and improved self-reported outcomes. The control groups showed little change. Neither the functional or cognitive approach appeared to be better, both were equally effective. The cognitive performances did not create long-term effects, whereas the functional approach demonstrated real-world effectiveness. The characteristics of the participants did have some effect on the outcomes. An integration approach was best supported.
Overall, the results across the studies were mixed. Many findings were inconsistent, and several authors emphasized the need for additional research. In particular, more studies are needed on technology-based interventions targeting attention and orientation. The evidence suggested that using a combination of intervention methods tends to be more effective than relying on a single approach. Functional task-based interventions also appeared to produce better long-term outcomes because they are more transferable to daily activities. Another key finding was that earlier intervention after TBI was associated with better outcomes. However, the results were also influenced by factors such as injury severity and individual participant characteristics. Participants generally had more difficulty with higher complexity tasks, but overall, structured rehab programs showed more benefits in improving attention and orientation. The studies consistently showed significant and persistent deficits in visual and visuospatial attention after TBI. These impairments occurred across all severity levels, but more severe injuries were linked to larger and longer lasting deficits. Not all types of attention were affected equally. Selective attention, attention orientation, and higher level top-down processes were more impaired than basic bottom-up attention. The research also suggested that earlier intervention, especially during the subacute phase, led to better outcomes compared to later treatment. While only small differences were found between specific training methods, structured cog rehab and attention-based interventions showed measurable benefits. Finally, more complex tasks were more difficult for participants, highlighting the impact of TBI on higher-level attentional control. For clinical practice, therapists should routinely assess visual and visuospatial attention, since these deficits are common and may persist long after a TBI. Interventions should focus on higher order attention skills because these are often the most affected and are closely related to functional performance. Early intervention, especially during the subacute phase, may lead to better outcomes, highlighting the importance of timely referral and treatment. OT interventions should emphasize structured, functional, and task-based attention training that carries over to real-world activities such as driving, medication management, work tasks, and community mobility. Therapists should also consider injury severity and task complexity when grading activities, since more complex attentional demands often create greater difficulty. Finally, ongoing monitoring of attention over time can help guide rehab planning, track recovery, and support patient and caregiver education. OTs can use technology and computer-based programs as preparatory activities before moving into more structured attention and orientation training. Understanding the importance of early intervention can also help OTs recognize different phases of recovery and choose interventions that best match the client's stage of rehab. Metacog training can be used to help clients develop greater self-awareness and learn strategies to manage their own cog challenges. Using task-based, meaningful, and functional activities can lead to better outcomes because the skills practiced are directly relevant to daily life. Finally, combining multiple intervention types during therapy may provide the greatest benefit for clients recovering from TBI. Future research should continue exploring technology-based interventions, as current evidence shows potential, but it's still limited compared to traditional OT approaches. Studies could also benefit from examining participant characteristics like age, gender, injury severity, since these factors may influence outcomes. Another area of research in the relationship between specific brain regions affected by TBI and visual attention deficits, although more neuroimaging research is likely needed to clarify this connection. Future work should also examine the optimal timing of treatment, since earlier intervention appears beneficial, but the most effective therapeutic window is not clearly defined. Finally, more research comparing combined interventions versus single approaches could help determine whether multi-model treatment leads to better real-world outcomes. For the discussion questions, our first one is, what are some barriers you might approach in a clinical setting when working with a client who demonstrates orientation and attention deficits? Our second is, what are some aspects that might alter which type of intervention you would use with a client with TBI and attention and orientation impairments? Our third one is, what challenges might come when assessing attention deficits in individuals with TBI, and how could those challenges influence the way you evaluate and interpret their performance?